Hello there, young doctors. Welcome to ASAN Network. I am your Dr.Salauddin, MBBS MS Orthopaedics, and this is our fracture classification series. Now, we are continuing with our humerus fracture classification. So, in humerus fracture classification, we have completed the proximal humerus fracture classification. Then we have also completed the shaft of humerus fracture classification. Now today we will be discussing about the distal humerus fracture classification. Before going into the distal humerus fractures, we will be discussing a little bit about its orientation and anatomy. Okay, so in the embryological staging, when the baby is developing, both the upper limbs and the lower limbs will be oriented towards front, but they go a 180 degrees of rotation. The forearms rotate anteriorly so that your palms will be facing anteriorly, and the legs will be rotated posteriorly so that your plantar aspect of the foot will be oriented towards posteriorly. Okay, so keeping in this mind, we will see the anatomy of the distal humerus. See, this is the anteriorly oriented distal humerus, where the condyles, the medial and the lateral condyles are anterior, and so this is the humerus shaft, and the condyles are making an angle of 40 degrees, to the anteriorly, and the columns, this is the medial column and this is the lateral column. Okay, so the distal humerus will make an angle of about 40 degrees with respect to the shaft of the humerus, and both the columns are not in a similar fashion, they are asymmetric triangle, they form an asymmetric triangle. Okay, so the medial column here, this is the medial articular surface, this is the capitulum, this is the trochlea, this is the trochlea. In trochlea also, this is the medial most part and this is the lateral most part, and this is the medial condyle and this is the lateral condyle. So the lateral condyle, as you can see above, it is in teardrop shape. Okay, and the medial condyle, the medial column, it is in the triangular shape. The medial column is triangular and the lateral column is teardrop shape. Okay, so the lateral column is teardrop in cross section and it will resist torsional bending better. Okay, so it can resist torsional bending better, and the medial column, it is triangular, so it will be more susceptible to shearing and torsional forces. Okay, so which breaks in shearing and torsional forces first? The medial column will break first. And coming to, as I have told you, this is the trochlea. Okay, trochlea is again having the medial most part and the lateral most part. As you can see, if you draw a horizontal line, the medial most part of the trochlea is more distal. Okay, so when it forms an articulation with the ulna will not be in a straight line, it will be little deviated towards the lateral aspect. Okay, so this forms the basis for the carrying angle of the elbow. Okay, so this is mainly helpful for bringing the hand towards the mouth. Hand to mouth action is because of this one single point, that is the medial part of the trochlea is more distal and it forms the carrying angle. So, the medial trochlea will extend more distally than the lateral trochlea and the capitulum, and this is the normal valgus carrying angle of the elbow. So, how much it is in elbow full extension? It is 6 degrees of valgus angle, and carrying angle is more in females than in males. This you know in from the first year of your anatomy, because the females have wider pelvis, the carrying angle for the females will be more. What is a tie arch? As we have discussed in the previous slide, that the distal humerus has two columns, that is the lateral column and the medial column. The lateral column has the capitulum and the some part of the trochlea, and medial side it has some part of the trochlea and the medial condyle. Combining these two will form the tie arch. See, the lateral column, the medial column, the capitulum, the trochlea and the medial condyle all together will form an tie arch. Okay. So, the medial and the lateral columns support the articular segment of the distal humerus, and the capitulum is the distal most part of the lateral column. As you can see, the lateral column, the distal most part is the capitulum, and the medial epicondyle is the distal most part of the medial column, which does not help any in articulation. So, it is a non-articular structure, and trochlea lies medially within the articular segment positioned between both the capitulum and the medial epicondyle. So, this articular segment that functions architecturally as an tie arch. So, this is the basic anatomy that you have to remember before going into the distal humerus classification. So, coming to the distal humerus fracture classification. So, in adults we have given the descriptive classification, the AO classification system. For the condyles we have the Mills classification system and Jupiter classification system for both the columns. The two column fracture classification is given by the Jupiter, and the capitulum fracture and the trochlear fracture. It is not an classification, but the other name for trochlear fracture you must remember, that is log ear fracture. The log ear fracture is also called as the trochlear fracture. Okay. And finally, the articular fracture classification, that is given by Ring et al. We will discuss each of these classifications in detail, and also we have included pediatric classifications, that is most important for the distal humerus, that will be regularly asked in your exams, that is the supracondylar fracture, the Gartland classification, and the condylar fracture, that is the Mills classification in pediatric age group. Okay. So, we will discuss each of these classifications. So, coming to descriptive classification, is just a descriptive classification where the supracondylar fractures are divided into extension type and flexion type, where it's just describing the fracture line where it is going. So, if it is above the condyles, it is supracondylar. If it is through the condyles, it is transcondylar. In between the condyles, it is intercondylar, and if individual condyles are fractured, it is condylar fracture. Then each part of the distal humerus, if it is fracturing, that is the capital fracture, the trochlear fracture, the lateral epicondyle and the medial epicondyle fractures, and fractures of the supracondylar process. This is the bony projection in the supracondylar area. The supracondylar process is a bony projection over the supracondylar area. This is the descriptive classification. Now, we will go in detail about the AO classification system. As we already discussed in the previous proximal and the shaft humerus classifications, AO is an alpha-numerical classification. The distal humerus is an articular part. It forms the articular, that is the elbow joint. We simply divide the fractures into extra-articular, partial articular and complete articular fractures. Now, we will go into the AO distal humerus fractures. See, articular segments, the AO classification gives it as extra-articular, partial articular and complete articular fractures. We have discussed humerus is given the number 1 and the proximal humerus is 1, 1, the shaft is 1, 2 and the distal humerus is 1, 3. So 13A is extra-articular, 13B is partial articular, and 13C is complete articular. So we will discuss individually the extra articular, partial and the complete articulars. So 13A, the extra articular, is again subdivided into A1, A2 and A3. So the A1 type is an avulsion type of fracture. Either the lateral epicondyle or the medial epicondyle gets avulsed. So you can see in the image, this is the lateral epicondyle getting avulsed, this is the medial epicondyle getting avulsed. So this is 13A1 and this is 13A1.2. This is 13A1.1. So 13A2 is simple fracture. Either it can be spiral, oblique or transverse, which is an extra-articular fracture. So you can see in the image, this is an spiral fracture, this is an oblique fracture and this is an transverse fracture. So if it is spiral, you give it as 13A2.1. If it is an oblique fracture, you give it as 13A2.2. Spiral, oblique and transverse. Transverse is 13A2.3. Coming to 13A3. The A3 is wedge or multifragmentary fracture. So if the wedge is intact, it is 3.1. If it is the wedge is fragmentary, 3.2, and if the wedge is multifragmentary, it is 3.3. 13A3, 3.1 if the wedge is intact. The wedge is fragmented. Okay. So here it is 13A3.2. The wedge is multifragmentary. You can see the wedge is multifragmentary. So it is 3.3. Okay. Coming to 13B, the partial articular. So 13B1 is sagittal, lateral sagittal fracture. 13B2 is medial sagittal fracture and 13B3 is frontal or coronal plane fracture. Okay. So the 13B here, 13B, you divide it basis on plane of the fracture. So you divide 13B partial articular fractures into plane of the fractures. Okay. So if it is lateral sagittal, it is B1, medial sagittal B2 and coronal plane it is B3. So B1 lateral sagittal again divided if the fracture is going through transtrochlear. If it is simple transtrochlear fracture, it is B1.1. If it is going to the capitulum, it is B1.2. If the fracture is multifragmentary through the transtrochlear area, it is B1.3. Coming to medial sagittal fractures, if the medial sagittal fracture is going through the transtrochlear groove, it is B2.1. If it is going through the medial articular surface, it is B2.2, and if it is going multifragmentary through the medial articular surface, it is B2.3. Coming to the frontal or the coronal plane fractures, it is fractured in the coronal plane. If the capitulum is fractured, it is B3.1. If the trochlea itself is fractured, it is B3.2. If both the capitulum and the trochlea is fractured, it is B3.3. So this is the partial articular fractures. Remember this frontal or coronal plane fracture 13B3. Okay. The 13B3, you remember in the distal femur also. What do you call the distal femur coronal plane fracture? This is an homework for you. You tell in the comment section what do you call the distal femur coronal plane fracture. I will tell you in the next video. Okay. So coming to 13C, complete articular fractures. 13C1, the articular surface is simple fracture and the metaphyseal fracture is also simple. then it is C1. It has C1.1 and 1.3. So if it is above the transcondylar axis, this is the transcondylar axis. If it is above, then it is C1.1. If it is through the transcondylar axis, it is C1.3. There is no C1.2 in complete articular fractures. Okay. So C2, the articular part is simple, but the metaphyseal part is multifragmentary. Okay, that is C2. So the articular part is simple. In all three, the articular part is simple. For the intact wedge, it is C2.1. If it is fragmentary wedge, it is C2.2. If it is multifragmentary, it is C2.3. C3, where both the articular and the metaphyseal parts are multifragmentary, we call it as 13C3. The articular and the metaphyseal areas both are multifragmentary. So if it is simple metaphyseal, it is C3.1. If it is wedge metaphyseal, it is C3.2. If the metaphysis is completely multifragmentary, it is C3.3. In this X-ray, can anyone tell me what type of AO classification comes it is? Whether it is an articular or extra articular. We will trace out the fracture line. Here is the fracture line going, okay, here, and it's going here also, and it has going here also. This is the fracture line. Now can you tell me whether it is extra articular or complete articular or partial articular? This is not extra articular because the fracture line is going through the joint. It is articular. Now we have to go whether it is partial articular or complete articular. In partial articular, you get only the parts are fractured like capitulum, trochlea, medial condyle or the lateral condyle. Only that parts are fractured. But here it is directly going into the joint. So this is a type of complete articular fracture. What do you call complete articular fractures in AO? Humerus is given as 1, distal humerus is given as 3, complete is given as C. Okay, this is 1, 3, C. Now we have to determine whether it is C1, C2 or C3. C1 is simple, both the articular surface and the metaphyseal surface both are simple. In C2, articular surface is simple, but metaphyseous is multifragmentary or wedge. In C3, both are multifragmentary. The fracture line is going only once. There are no multifragments. Simple metaphyseal fracture. Here the articular part is simple articular fracture. So both are simple. It comes as C1. So it is 1, 3, C1. In C1 also you have C1.1, C1.3. So 1.1 is if the fracture is above the transcondylar axis or through the transcondylar axis. So can anyone tell me if it is above or below? It is not above, it is going through the transcondylar axis. So here is the transcondylar axis and the fracture is going through the transcondylar axis. If it is going through the transcondylar axis, it is 1, 3, C1.3. This is through the transcondylar and C is above the transcondylar axis. So this X-ray is an AO type 13C1.3 type of fracture. Coming to Jupiter classification, it is also called as Mahne and Mata classification. Jupiter classification is for both the columns. If both the columns are involved, it is Jupiter classification. There is a mnemonic for this. You can remember it as T, Y, H and lambda. These letters indicate the fracture pattern. So in Jupiter classification, you remember these letters for remembering the fracture classification pattern. Okay, T, Y, H and lambda. So first one is high T, that is the metaphyseal fracture is above the transcondylar axis, that is high T. If the fracture is going through the transcondylar axis, that is low T. Coming to Y type of classification, where the fracture is in a shape of Y. This is Y and this is H. The medial condyle is separated, the capitulum is separated, and the fracture is again going through the transcondylar axis. This is a H type of fracture. And it is medial lambda, where the metaphyseal fracture is exiting through the medial condyle and it is going through the transtrochlear groove, medial lambda. And if it is the fracture, metaphyseal fracture is going through the capitulum and through the transtrochlear groove, it is lateral lambda. Okay, this is as simple as such. This is Jupiter, Mehna and Mehta classification system. Next is our condylar fractures given by Mills classification system. So individually lateral condyle and medial condyle we will discuss. First, the lateral condyle fractures. So it's divided into type 1 and type 2 based on the stability, the dislocation risk and the mechanism of the fracture. The main part that we have to remember is the lateral trochlear ridge near the capitulum. The lateral trochlear part, if it is intact, it is type 1. If it is intact, it is more stable and there is low risk of dislocation of radius and ulna. And the mechanism, the ridge prevents the displacement. Why it is more stable? Because the trochlear ridge will prevent the displacement. If it is fractured along with the lateral condyle, it becomes less stable and there is more chances of dislocation, and there is also medial capsulo-ligamentous disruption. Okay, because of the dislocation force, the mediocapsular ligaments will also get torn. Okay, so you can see in the image, first is the fracture is going through the transtrochlear ridge, but the lateral trochlear ridge is intact. In type 1, the lateral trochlear ridge is intact, so there are no chances of dislocation. The medial capsulo-ligamentous structures are also intact in type 1, but in type 2, the fracture is going through the transtrochlear ridge and the ridge is not intact, the ridge has disrupted. Here is the disrupted ridge part. Here again, because of that disruption, the medial capsulo-ligamentous structures are torn and the radius and ulna will be dislocated. Coming to medial condylar fractures. The medial condylar fractures, type 1, it is the lateral trochlear ridge only plays the main important role. If it is intact, it will be more stable and there is less chance of dislocation. And medial condyle is fractured and the trochlear ridge is also fractured, it becomes less stable, there is more chance of dislocation. Here opposite happens, the lateral capsulo-ligamentous disruption will occur. You can see in the image, see the fracture is only to the medial condyle, the lateral trochlear ridge is intact here. So this is type 1, there is no chance of dislocation, but the lateral trochlear ridge has been disrupted here and the lateral capsulo-ligamentous structures will get torn and there is more chance of dislocation. This is type 2 Mills medial condyle. The main for Mills classification system, you have to remember the lateral trochlear ridge. The lateral trochlear ridge is for the Mills classification, if it is intact or not. Coming to pediatric classifications, the same pediatric Mills classification. Here also it is similar, the main lateral trochlear ridge we are talking, but in addition to that, the pediatric we have the ossification centers. If the fracture is going through the ossification center, it is type 1, and if the fracture is through the trochlea involving the lateral ridge, type 2. Here also same, the type 1, the lateral trochlear ridge is intact and it will be more stable and there is low instability chances. In type 2, the lateral trochlear ridge will get disrupted, less stable and there is more chance of translocation and ligamentous injury. Condylar pediatric Milch classification. Coming to capitulum fractures, this is a little bit interesting because we have different names for the each type of capitulum fracture. Here is the 4 types of capitulum fractures. The first one is called as Han and Stinthal fragment. The second one is called as Cocker-Lawrence fragment. Third is Morris fragment, and type 4 is called as McKee's fragment. We will see the image and we will come to the description. You will understand better. So the type 1, first is Han and Stinthal fragment. The Han and Stinthal fragment, if you see in the coronal view, along with the articular surface, you have a large chunk of subchondral bone. You have a large chunk of subchondral bone and the fracture is in the coronal plane. So if the capitulum fracture involves the articular surface and there is a large subchondral bone, it is type 1 Han and Stinthal type of fragment. Then type 2, it is only the articular surface with thin rim of subchondral bone. The subchondral bone is very thin. It involves the articular surface and the thin layer of subchondral bone. This is called as Cocker-Lawrence fragment. This is type 2 capitulum fracture. You can imagine as if as an cap has come out. Here the cap has come out in type 2. The type 3 is there is combination of the capitulum. It is fracture, and if the fracture extends into the trochlea along with the capitulum, if the trochlea is fractured, it is type 4, also called as McKee fragment. This is the capitulum fracture. Coming to the articular fracture of the distal humerus given by Ring et al. There are 5 types based on the articular fracture. First, he will start at the lateral most, that is the capitulum and the trochlea. This is the trochlear part. Okay, this is the trochlear part and this is the capitular part. So type 1 is involving the capitulum and the lateral trochlear part. Here if it is involving the capitulum and the lateral trochlear part, it is type 1. If along with type 1, if it involves the lateral epicondyle, it is type 2. Okay, capitulum and lateral trochlea is type 1. Along with type 1, lateral epicondyle is type 2. Along with type 2, if it involves behind the capitulum with posterior bone impaction, behind the capitulum with posterior bone impaction, it is type 3. If along with type 3, the posterior trochlea is also involved, it is type 4. This is the posterior trochlea getting involved, and if it is the medial condyle getting fractured, then it is the type 5 fracture of articular surface given by Ring et al. It is simple as. Coming to supracondylar fracture, the most commonly asked in the exams, that is Gartland classification. The supracondylar humerus fracture, the Gartland classification system is divided into 2 types, that is the extension type and the flexion type. The most common is the extension type with 98% of the incidence, and flexion type is only 2% type. So either it is extension type or the flexion type. It is divided into 4 types. First is the fracture is undisplaced or minimally displaced less than 2 mm. Type 2 is if it is displaced more than 2 mm but it has an intact posterior cortex, that is hinged to an intact posterior cortex. This is type 2. Type 3 is completely displaced, there is no contact with the cortex. It is type 3. Type 4 is displaced but it has multidirectional instability and incomplete periosteal hinge. It is unstable in both flexion and extension. This is type 4 of Gartland. You can see the type 1 is there is a fracture but it is not displaced. So it is type 1. There is a fracture, it is displaced but it is having a intact posterior cortex, that is type 2. In type 3, there is a complete fracture and both the fracture fragments are displaced completely and there is no contact, that is type 3. And in type 4 there is complete displacement of the fracture with multi-directional instability. The distal fragment can go either medially or laterally and in flexion or extension. Now we will see some examples of real life x-rays where you have to classify the supracondylar fracture into each type. So this is an x-ray of an kid. Now you tell me where is the fracture and what type of supracondylar fracture is according to Gotland classification. Here is the fracture line in AP view. In AP, is it displaced? No, no much displacement. Again in lateral view, here is the fracture. Okay, either it is displaced much? No, here it is also not displaced. So it is undisplaced supracondylar fracture. You can given it as type 1 of Gotland. So here you can see in the AP view, here is the fracture line, and in lateral view you can see here is the fracture line. But if you closely observe, here the posterior cortex is intact. Okay, so if the posterior cortex is intact, it is type 2 of Gotland. Here is in this x-ray, here is the fracture line in the AP view, and in lateral view the distal humerus fragment is completely displaced. Here is the shaft and here is the distal humerus. It is completely displaced and there is no cortical contact. There is no cortical contact. So it is type 3 of Gotland. Here also in AP view you can see there is complete displacement of the fracture and it has gone laterally. Distal fragment has displaced laterally, and in lateral view there is no contact with the distal fragment and it has gone completely posteriorly into extension posteriorly. So in both the AP and the lateral view the distal fragment is not stable. So it is multi-directional instability. So if there is complete fracture, multi-directional instability, it is Gotland type 4. Okay, thank you guys. Here comes our session to close. So please like, share and subscribe to my ASAN network. It helps me in improving and presenting you more videos. So in the next video we will be discussing about the forearm radius and ulna bone fractures. Okay, we will be discussing the ulna, proximal end, shaft and the distal radius fracture classification systems. Thank you.